Good evening. I'd like to acknowledge the local custodians of the land in which we meet this evening and honour elders past, present and emerging. I'm Melissa Wilkinson from the education team at the Primary Health Network. Welcome. We're here tonight for the Polypharmacy event. It's a very interesting topic, and I'd like to thank all the presenters for being here with us this evening. Just a little bit of housekeeping. I encourage you to answer our poll. This is the way that we track information and feedback, and it's vital for us to deliver further education, so please complete that. A copy of this will be available in our education library over the coming days of the recording and also the presentation. So if you've visiting notes, you'll be able to access them there as well. I'm going to hand over now to our GP facilitator for this evening, Dr. Georgia Page. Thank you, Georgia.
Yep, thank you, Mel. So I'm Georgia Page. I'm a GP in Erina, and we've got a great panel lined up today to talk to us about polypharmacy, which is becoming more prevalent with our ageing population, and it can be very much a fine balance between managing disease and avoiding adverse effects and interactions. And monitoring medications is very time-consuming in general practice, and that's where a multidisciplinary approach can help us to assist us with these patients, and that's where our people like our community pharmacist is very useful. So I'll choose our first speaker, Josh Cox, who's a pharmacist at Womberall, and I've certainly found him very handy when I need to call about patients that definitely have polypharmacy going on. So thank you, Josh.
No worries. All right, let's get started. I hope everyone can see my screen here. Have you got access to that, Georgia? Can you see the screen?
Yes.
Yep.
All right, let's get started. So first of all, thanks everyone for having me on here today. I really appreciate it. Something different out of the week. So as Georgia said, my name is Joshua Cox. So I currently manage a community pharmacy here on the Central Coast of Womberall. So we're a pharmacist advice pharmacy. We're very much patient-centered and sort of service-based. So I spend about 2/3 of my time running and managing a community pharmacy, and the other third of my time I usually spend doing medication reviews, both for local GPs and also some consultancy work on the side for a number of insurance companies for CTP and workers' compensation claims. So I have like a reasonable amount of experience with complex patients, and I do quite enjoy the challenge of multiple medicines and using our clinical knowledge that we learn so much about when we're training. So we'll get straight into it. I hope everyone can hear me okay. Yep. Perfect.
All good.
Let's go ahead. So look, I'm going to try to make this as sort of factual and not as content heavy as possible. I know Dimity has some interesting case studies to go through as we get further into her section. So I'm going to try to make this as informative without being too heavy on the content. So that's what we'll be going through today. So a brief introduction, some current trends in Australia and our specific region, the implications of polypharmacy and multiple medicines, how we manage it in a primary healthcare setting, and then we'll move into de-prescribing and also some of the tools that we can use in management and medication reviews. So look, feel free to send your questions through, but I believe we're withholding question time till the end of all the presentations tonight. So let's get started. So what is polypharmacy? Anyone that's in the healthcare industry sort of understands what that is. Look, there's no perfect definition. As a general rule, it's basically greater than 5 prescribed medicine. So in Australia, all of our data regarding polypharmacy actually comes from PBS dispensing data in community pharmacies. So that's, you go to your local pharmacy, you get a PBS subsidised script, and that goes onto a big database, which then they collate and organise. This is done with patients above 75 years old. So in regards to this data, there are some limitations. The most important being that it is only for above 75 years. So it doesn't include sort of complex patients that are below that age. So we're looking at, people with disabilities, type 1 diabetics, complex asthma patients, and things like that. So some of the other limitations are that it doesn't include private items. So about 20% of all prescriptions are non-PBS. So this basically means that these numbers are actually less than the actual prevalence. So I'm getting lots of things through. So what are the trends of polypharmacy across Australia? So look, rates of polypharmacy are definitely higher in major cities and inner regional areas. Outer regional areas, that rate tends to drop. In super remote areas, it's rising again, obviously due to you know, some socioeconomic changes in remote areas. So look, the little graph here just explains that out of the 100% of people that take 5 or more meds, we're still considering 50% of them take 7 or more, and even 10% are on 11 or more medicines. What this data does not explain is like more complex patients, lots of over-the-counter items, herbal products, things they get from a supermarket, from a health food shop, or you know, things that are bought online that aren't recognised as PBS medicines. As we go through, look, we can see on the map here of Australia, there's huge discrepancies. It's quite hard to really get standardized data due to different population levels, particularly in remote areas, but we can see there's 6.4 times as high in the highest rate compared to the lowest rate in regards to polypharmacy. So even within our local regional areas, there's quite a lot of variation. And it does make it really hard to direct funding and, you know, and sort of further investment. There's not enough sort of data belonging to this. So let's look at our area of focus, so Hunter, New England and Central Coast. As we can see, it sort of ranges from, you know, the 50,000 people, probably more of a aged population on the Central Coast and Lower Hunter, and then potentially a younger generation as you travel more remote, which means usually the polypharmacy rates are going to be a bit lower. And again, the data is quite hard to determine when you have small population areas, particularly like, you know, areas like the far upper Hunter and sort of the top of the New England area. The data may not be that accurate. So what are the implications of polypharmacy? You know, what are the problems with people taking multiple medicines, and why is that so important as far as where we direct our time and effort? So first of all, as the bureaucrats would be interested in, what's the money? What's it cost the government? So current estimates suggest that 2 to 3% of all hospital admissions are directly related to medication issues. So that would be, you know, John Smith has taken too many NSAIDs. He's now got gastric reflux and he presents at the hospital as a direct result of that. Indirect estimates are many-fold higher, and that would usually be recognised, you know, later in, not just the hospital admission. So perhaps when they're admitted to a ward, investigations may continue, and there's usually some sort of medication involvement. So this works out to be about $1.5 billion a year for the taxpayer, and probably about over $250,000 of hospital admissions per year. So it's such a big number. So what are the risks associated with polypharmacy? So as Georgia mentioned before, complex medicines means there's lots of drug interactions. So these can include drug-to-drug interactions. So something like that would be perhaps an ACE inhibitor and a non-steroidal anti-inflammatory drug. We can consider drug health interactions. So that would be something like a beta blocker with maybe uncontrolled asthma. And then also the other risks are related to adherence and compliance. So the more complex a medication regime, the less likely the patient is to wanting to take the medication. And also the more likely they are to sort of miss and take multiple doses of that same medicine. All right, so what are the implications of polypharmacy for the individual patient? So there's lots of evidence and research gone into this, and they've found that regardless of the type of medicine that people take, there's a much higher risk of delirium, risk of falls, reduced quality of life, overall higher levels of sickness and death, and hospitalization, as we mentioned before. We also often fail to consider the sort of the non-health related implications. This can include cost to the patient. Patients may be on a number of medicines they no longer need to be. And look, for your average pensioner, this may be significant, as even subsidised meds can accumulate in cost. And also lifestyle implications, which is the big one that I see. People taking multiple medicines multiple times a day, it does become quite difficult to manage. It might limit their ability to go on holidays. It might limit their ability to, potentially, go do things on a day-to-day basis, to exercise, to go to dinner, and that's sort of another thing that we can consider. So we know it's a problem. We know the implications, but how do we manage polypharmacy? So, as always, with management processes, the first process is basically going to be some sort of structural framework, which is always quite difficult to sort of wrap your head around. So this one here, I'm not going to read it out, but the International Group for Reducing Appropriate Medication, they basically have 10 recommendations. Now, I have summarized this, paraphrased it, and made it as quick and simple. So I'll quickly just brush over this. So first of all, it considers the importance of reviewing medication with an idea of de-prescribing if possible. It talks about identifying individual patient characteristics and preferences before starting just a novel medication. It talks about considering each medication for potential withdrawal. Then we talk about mixed implicit and explicit approaches, so no right, 100% right or 100% wrong approach to individual medicine. We might also consider that clinical trials and safety data very rarely includes elderly and geriatric patients. So we're not really that sure a lot of our regular medicines, how safe they are in elderly people. Commercial influences, so that could include, the advertising of a new product might skew starting new medicines, stopping old medicines. And then the next few are just to do with sort of the role of how we can educate, medical professionals. So talking about prioritizing of skills, regularly reviewing methods to stop treatments. I know there's a lot of information regarding starting new medicines, but the information regarding stopping them is quite hard to find. So also we can mention the single disease model. So very common with a single disease and a simple patient, but with multiple comorbidities, the single disease model is almost useless. And then we want to talk about what are the expectations for the particular patient. So, is there a necessity to continue statins at end of life care? Those type of options regarding quality of life and realistic expectations and health outcomes. So we have the framework, which all sounds well and good. So how do we actually put it into practice? How do we empower the patient, the pharmacist, or the GP to do this? So in regards to the patient, I usually recommend the patient to minimize the number of prescribers they go to. You see that a lot in general practice. There's no issue with the patient visiting multiple prescribers within the same practice. Where a lot of the issues come is multiple GP practices. There's obviously information that's lost, and there's no consistency of care. Same concept with a pharmacy. Multiple pharmacies are not going to have an adequate history, and it also just the risk of duplication of medicine. The patient can also have their own dose set box, and they can keep an up-to-date medication list themselves in case they get hospitalized or visit specialists. In regards to the pharmacist, medicine brand changes is a big one in managing polypharmacy. As a pharmacist myself, I'm constantly trying to get the same brand in. Often it's really hard. We're a really small country and we don't have a lot of buying power, so we're constantly changing medicine. So the role of the pharmacy is to make sure that they label it correctly. The next thing is a spelling error, but the in-pharmacy meds check service, which is a very informal, quick summary of the patient's medicine. We can recommend Webster packing or your dose administration aids. And the role of the pharmacist is to recognise any changes in dispensing. So if a particular patient's getting a month worth of medication, it's up to the patient to recognise if they're getting it every 2 weeks, every 6 weeks, every 3 months, and basically to question that. Now, for most of the people who are viewing this video today, this session is probably a bit more applicable. So how can a GP or a regular prescriber, how can they help manage polypharmacy in their own setting? So again, having an up-to-date medication list is important. A big one that I see is, and it's not always on the onus of the GP, often this is due to the particular specialist not sending through the information, but just ensuring documentation from other prescribers is addressed and also it's updated. So often we see in my medication reviews that a GP may be completely unaware of a complete change of medication or, you know, an addition. And, you know, this becomes difficult to manage because the GP is in the dark as much as the pharmacist that's there. And generally it's quite hard to contact specialists. So that's another big thing that I think is useful. Another trick that I know a lot of local doctors do around here, particularly with patients taking complex medications, is just maintaining more frequent appointments. So rather than giving 6 months of your regular repeats, some GPs will just provide 3 months, even for your normal statins and your antihypertensives. What this means is obviously the patient is returning to the medical centre by choice. You know, they can't hide any regular appointments and get more repeats. So, you know, this also benefits with remuneration, particularly because these patients tend to take a lot more time. Another thing which has just become legislation is your digital prescribing now is active ingredient rather than brand name. So this makes life a bit easier. And then being aware of the prescribing cascade. So I do see this a lot in practice when I'm reviewing medications lists. The prescribing cascade, for anyone that doesn't know it or isn't aware, is basically where one medication is prescribed for the side effects of the other. And that just continues on and on. So an example of this would be a patient being on a non-steroidal anti-inflammatory for an extended period of time, more than the recommended time. They then perhaps get prescribed a PPI, which they take for a number of months, 6-9 months. And consequently, a blood test has resulted in, you know, maybe reduced levels of some of your fat-soluble vitamins, like your vitamin D, and the patient is then prescribed a vitamin D supplement. So the prescribing cascade is something which is really easy, you know, to sort of get missed because often you're just monitoring the patient at the time, and you may forget that, you know, potentially that could have been resolved a few steps back. The other thing a GP can do is also just reassess the current goals of care. So as we mentioned before, just having realistic expectations about particular patients. So particularly this is obvious in palliative care, where we see this a lot with a lot of de-prescribing. Advanced, really unwell people above 80 years old, cancer patients, and patients where perhaps you know, a risk-benefit analysis has to be made up regarding particular medicines. Another thing which we talked about previously with the other panelists today was reviewing relevant drug interactions. Now, this is the domain of a pharmacist, and I do understand that this is a big proportion of our job, but look, some GP practices might find it useful to have a particular drug interaction program. Unfortunately, I had a quick look this afternoon. There's no decent ones that are free, as far as I'm aware, and most of the ones that are free are usually based on other countries, so US data and US guidelines. So two of the most common ones that we tend to use a lot, OSDI and your eMIMS. So I'll just go on to the next page. So look, these are programs that you do have to pay for. They're anywhere between $200, or I think $150 and $300 a year. They are very good interactions, but look, please don't hesitate to call your local pharmacy, particularly if you have one next door to your practice, or a local pharmacist that you can speak to, because often we have access to these. People that work for New South Wales Health will usually have access to the eMIMS database or equivalent through their up-to-date program, and most people that are employed with your universities will also have access to these particular databases free of charge. So as you can see here, you can put in up to, I think, 30 or 40 drugs. It will then prioritize them based on severity. And then the next step is basically, it'll go through the important stuff, so what the actual mechanism of interaction is, and more importantly, how do we manage it? So if the patient does have to take 2 concurrent drugs that interact with each other, it goes through a few steps on how to manage it, which is quite handy. So the next part is just medications of concern. So look, all of these are drugs that anyone that prescribes are familiar with. There's nothing out of the normal here. But look, the current guidelines recognise a number of medications that should be reviewed with elderly people. As we know, with advanced age comes changes in body weight, fragility. We mentioned before changes in goals of care, what kind of outcomes we're trying to get out of the care, and also reduced like renal and liver function can result in almost changed pharmacodynamics and pharmacokinetics. And look, these can be quite noticeable. So I know Dimity in a little while is going to go through some of these interactions that, contraindications and interactions and things that she's seen in some of her medical reviews. So I won't go into it too much, but these are sort of your normal high risk drugs. So opioids, benzodiazepines and hypnotics. As you get older, the clearance of the drug is reduced, the chance of accumulating those metabolic byproducts is increased, the half-life is increased, and there's often an accumulation of these drugs in the patient. So this can result in a huge risk of falls, and also a risk of delirium and other sort of psychotic almost symptoms in some people. So we also have the drugs with a narrow therapeutic window like digoxin, clozapine, valproate, and also drugs with additive anticholinergic effects, which we'll go through a little bit later. So how do we de-prescribe? Look, the primary health network does have a huge amount of resources regarding this. The New South Wales tag also has a lot on opioids. There is recently, in the last 5 years, I think the amount of these documents has quadrupled, because I used to find it quite difficult to find clear guidelines, when now there's plenty of them exist, so they're not very hard to find. So this is obviously the second part of my presentation, so I hope everyone is following and I'm not speaking too quickly. So this is just regarding the roles of medication management reviews, which is another tool that GPs can use. So 2 major types of medication reviews that we see in a sort of primary health setting. So you've got your RMMR, or your residential medication review, and your home medication review. Now, the meds check is something done just in pharmacy, but it is still considered a medication management review. Now, rather than going through the differences, I've got a little table on the next slide. So look, the basic crux of it is that just disregard the meds check. That's just done in the pharmacy. There's no involvement with the GP unless problems are found. And it's just basically a quick summary of the person's medicine. Now, the HMMR and the RMMR are quite in depth. They both involve a consultation from the pharmacist, and they both have quite decent remuneration for the GP that is doing it. So HMMR can be done every 12 months, and there are exceptions to this if the GP feels as though a particular patient is, would benefit from getting a home medicine review. So this can include someone who's had, say, a newly diabetic person, a recent discharge from hospital with multiple new medicines, post-MI, post-stroke, those type of things where someone's basically handed 5 or 6 new medicines. It's often a perfect time to do a HMMR, even if they have already had them. The RMMR is something a little bit more complex. It's very similar from a GP standpoint, but usually it's undertaken by an accredited pharmacist that has a contract with the aged care facility, and that's $106 per patient. So I won't go through this. It's very long-winded, but it's just a brief summary of the medication review cycle of care. So I'll quickly go over it. So the way that medications reviews work, it's usually initiated, it can be initiated by the pharmacist who's requesting it, but usually a GP will consider a patient, as appropriate for getting a medication review. They'll write the referral, a pharmacist will do an interview, and then a report, which is classed as a medication management plan. This is then passed on to the GP, who we'll often in the report find things like perhaps recommendations, how the patient stored medicines, any adverse effects that they have, and you're looking at things outside of the prescribed medicines that often the pharmacist will find. Health food shop, you know, their uncle has given it to them because it helped with their arthritis. You know, the list goes on and on. Then the GP can direct any changes that they want to happen with a general consult, and they can then direct needs. So often we may find that the patient might benefit from some allied health intervention, or they might benefit from a Webster pack, or you know, perhaps other sort of health changes. So you're more than welcome to have a look at that. There's quite a lot of information on that page, but that's sort of the cycle of care. You do find that traditionally the relationship between a pharmacist and a GP is very sort of omni or one directional, where it's, you know, a prescriber and a dispenser, and the patient is at the end of the line, and often that circle of care isn't really finished. So, you know, the medication review is a very important way of that interprofessional collaboration that obviously, you know, we're all striving to get. So, who's eligible for a HMMR? So, the list is there. The basic difference between a residential medication management review and a HMMR, they both have to be eligible for PBS subsidy, so an Australian citizen or equivalent. The difference is at RMMR, they only have to be a full-time resident, where a HMMR, they have to meet one of these requirements. It is quite flexible, the eligibility. A GP or a medical professional can literally tick a box that just says, I believe they're eligible, and as far as claiming goes, that is perfectly fine. So, what's the potential for growth in medication reviews? So, look, there is a huge potential of growth, not only in the Central Coast, Hunter, New England area, but Australia-wide. So, this statement here, so 15% of all patients in a GP setting, approximately, are eligible for a HMR. The rate is less than 0.5%. So, there is a huge potential not only for increasing practice revenue, but also increasing patient income. So if you imagine, I'm not sure how many people the average GP has on their books, but even if you were tentative and said, you know, 500 to 1,000 regular patients or something along those lines, 15% of that you could potentially be getting a home medicine review, which equates to $150 each person. So you're looking at tens of thousands of dollars a year, and yeah, and your time is used very appropriately. It's, you know, the referral and reading the review, and making a appointment, which is probably a special appointment anyway, I feel is, you know, very insignificant compared to doing it yourself. Look, like I said before, interprofessional collaboration is something we all strive for, and I believe that is improving between GPs and pharmacists, particularly in my local area here. And look, to facilitate that in the future, there is new software that is going to be linking between the My Health record, which will allow this process to be a little bit more streamlined. So that is coming, I believe, in the next couple of years. So that's all I have. So look, that's my presentation. I hope it wasn't too heavy for you. My email is at the end of this presentation. So anyone that has any drug-related questions or anything regarding the process, look, please feel free to write me an email, and look, through the email, I'm happy to give you my mobile number if there's any, you know, questions or anything that you'd like. Perfect. Thank you.
Oh, thanks, Josh. That was great, and especially it's interesting the rate of patients that are eligible for home medicine reviews, and our uptake is quite small. So it's certainly something we should be looking into a lot more. And I just have a quick question before I introduce Dimity. With the active ingredient prescribing, have you found that easier for patients? Or because the feedback from my patients is, I don't know what it is, I want the brand name. What's your experience?
Absolutely. Look, I think short term it's a difficult transition period. So people are so familiar with brand names, including myself. Like, I've got in the habit of even forgetting certain actual original drug names rather than remaining like Lipitor or something like that. Like, I know it's atorvastatin, but that type of thing. Look, I think short term, it is a difficult transition period. You know, a lot of the drugs are quite difficult to say. But long term, if people can be familiar with the actual drug name, it means the risk of them duplicating medicines is pretty low. And also, a lot of the generic brands now are actually the drug name. So, you know, atorvastatin, Sandoz, atorvastatin, APO. So they're also transitioning across. So hopefully it'll just become people being familiar with the drug name. But yeah, you're right. It has been challenging. A lot of people think the doctor hasn't given them the prescriptions. They think they've got the wrong thing. So yeah, very much so. Yep.
Another one of the challenges in general practice and pharmacy. So I'd love to introduce Timothy Pond. So she's an honorary professor of general practice at the University of Newcastle, and she is a special interest and has conducted much research in the area of aged care and dementia. And Dimity will be discussing polypharmacy, in particular with the older patients, and give us some interesting and practical examples of how useful a comprehensive medication review can be. Thank you, Dimity.
And thank you, Georgia. And thank you so much, Josh, for covering all that territory.
Oh, that's all right.
And giving me the fun part of talking about.
Yeah, you get to tell the fun stories now.
Yeah, I can. Now, can you see my screen yet? No?
Yep, we can.
Yep.
I'll just get you to put it on full screen because we can still see the notes. That's it.
Okay.
Perfect.
Here we go. Okay. So we talked about the indications for a medication review, and I'm not going to run through all of those again, but it is an item 900, which in our practice, we wait until, we have to send off a request for a medication review, and then we wait until we get the review back and we've discussed it with the patient. And at that point, that's when I charge the item 900. Then we're supposed to send a summary of our discussion back to the pharmacist, which in my case is often just a few notes on their review paper. So, and as Josh mentioned, there's heaps of scope for us to be doing more of these, and probably a need, in fact. And those were all the things. And Josh just run through those, so I can skip that. That's really good. And I'm going to talk to you about Mary. I've got 3 patients, all with pseudonyms, all starting with M. So forgive me if I get a bit confused about the 3. The first one's, most of my patients are elderly, by the way. I've got an interest in aged care. So Mary's 75 and on more than 7 prescription medications, and as Josh said, more than 4 actually makes you eligible for a medication review. So Mary had a history of generalized anxiety, and she was really anxious about her medications, and I couldn't work out why, but she was kind of a bit shaky about them all a few times. So I thought, well, you know, she's eligible for a medication review. Maybe the pharmacist can get to the bottom of this anxiety on a home visit, where the pharmacist actually spends quite a bit of time with the patient. So the pharmacist did a home visit. So the pharmacy is 2 steps down from our waiting room in my practice setup. So we actually know the pharmacist quite well, and they pop in with vaccines and things like that from time to time. So we keep in touch. So I got a report from the pharmacist, but I also had a chat to her. And so the first thing the pharmacist did was go through with Mary what each medication was and what it was for. So Mary is, as I say, a bit of an anxious person. She had all that written down and it was all correct. So that wasn't a problem. And I'd given the pharmacist the medication list. So and that was up to date. That is a good thing to do, actually, to make sure your medication list is up to date if you ask for a pharmacist review, because it's so easy for us to slip a bit with keeping our medication list up to date, and the pharmacist needs to know what they're on now. So she found Mary knowledgeable, and then she checked how Mary was taking the medications. That was fine as well. She could manage all the bottles and packages fine. Not always the case. I'll talk about that later. And then the pharmacist just thought, well, I can see she's anxious. I'll just check about the timing. Is she right on taking them at the right times? You know, TDS or whatever. So she found that Mary had a view that she couldn't take more than one tablet at a time, or that they would fizz in her stomach and make her unwell. And she does have a few tummy troubles, you know, probably associated with a bit of irritable bowel with her anxiety. And she didn't want any more of that. So what she was doing was setting her watch to remind her every 2 hours to take a tablet so that she would get through all her medications in the day. And the watch was dinging every 2 hours. And sometimes she told the pharmacist she missed hearing it, and then she was late with taking the tablet. And the whole thing had turned into a big drama. So, and that was something I had no idea about. So this is the advantage of having someone to discuss medications for a whole hour at home. So the pharmacist explained it was fine to take some of the tablets together and went through which ones. And then when Mary came back, having read the pharmacist's report and had a little chat to her about them, I reinforced that. And Mary was still very reluctant, very, very suspicious about this. But we agreed that she could take her over-the-counter vitamins all at the same time, because they're only vitamins and they wouldn't fizz. And she did manage that, and that reduced the number of times her watch was dinging at her during a day. And over the next couple of years, it became apparent that Mary has cognitive impairment, and now she's using a Webster pack, and so she's not worried about timing her medications to be separate anymore. But it was a very, very interesting pharmacy review, I thought. So thinking about medication management, we had a small group of our Newcastle students doing a research project. The poor things, they started in 2019 and they were going to visit nursing homes and look at medications. But of course, COVID came. So in 2020, they pivoted to doing telephone interviews with patients. And it was quite a drama, and they had to go through ethics a second time and so on. So in the end, they recruited participants aged 65 to 69. We wanted to avoid any suggestion of dementia because that's another ethics drama, that were living independently in the community and taking 5 or more regular medications, so would be eligible for pharmacy review. And these students managed 6 semi-structured interviews. Actually, we recruited 12 patients and they contacted 9 of them, but in the end, they only managed to sort of coincide timing and so on with 6. And those interviews over the phone were taped and recorded and transcribed and coded, which is a thing that they were learning really about, what we call qualitative research about interviews, and analysed thematically. And if anyone's interested, I've got a report which I'm happy to send anyway. So they found that the patients had a strong interest in their medication, and that these patients that they recruited were prescribed medications ranging from 5 to 15 different medications, and the daily pill count ranged from 4 to 22 doses. So a lot, you know, a number of them were on a lot of medications. The median was 11. So that's a lot of doses of medications in a day. And they found that there were a number of factors influencing medication adherence that were actually sort of outside the actual health of the patient. It did include their health perceptions, and it did include their outlook on life and their organisational skills, of course. Once you're getting up to 22.5 doses a day, you need organisational skills. and other factors. And these are some quotes which I thought were nice from the students' report. So I'm not going to read them out loud because you can read them yourself. But clearly the patients did little experiments with their medications, see if they were working or not. So if you happen to be doing a blood pressure when someone's in an experiment of not taking their medication, you might find it's unusually high that day, and they might not do it. They had strategies for remembering to take their medications, like sitting up with the salt and peppers and the cardas. And some of them, as I said, were taking a lot of medications. So P4 down in that bottom of that first column, sort of was counting out the medications. And up the top of the second column, you can see about the Webster pack, which for those of you not familiar, the pharmacist can prepare a Webster pack for a weekly fee that puts the medications into a container, and they can break open their AM, lunchtime, PM and night medications and just take it out of the Webster pack. They don't have to worry about getting those right. And they can easily see if they've taken their medications or not because the pack hasn't been opened if, you know, they've forgotten. And there were some quotes about trying to get the bottle open. Even the pharmacist had trouble opening the bottle in one case, and a pair of pliers was found to be helpful by one of the other patients. So these are practical things that we don't think about. People with arthritis have great difficulty opening bottles, and there's actually aids that you can get for that kind of problem, apart from pliers. So that's something to think about. So, okay, so Annette, pharmacy review in residential aged care, just to give you a flavour for that. So she was 82 and she lived in the local caravan park, in a van in the local caravan park for many years, and I looked after her there. And she was on a lot of medications, including 5 for intractable hypertension. 5, she'd had a number of hospital visits and they always tried to get her medications under control, but her hypertension under control, but it was still not very well controlled. It was very labile, and she'd had several 24-hour blood pressure readings, monitoring, which showed it. Sometimes it dipped really low, and other times it was really well over 150 on 100. So it was a worry. So she moved into res care, and in that particular facility, all new residents had a medication review. And I got to read the report. And the pharmacist noted on that report that she was taking high doses of licorice as an aperient because she tended to be constipated. And this had never been previously noted. I had no idea she took high doses of licorice. It wouldn't have probably meant anything to me at that stage. But in fact, licorice causes high blood pressure. And there's a little quote there from it's actually the New Zealand College Journal there, about licorice. And, it's one of those, it's not even an over-the-counter medication. It's, it's a natural product. And some of these are not without harms. So we need to really be aware of some of these things and have some way of checking. And your pharmacist may well be able to help you there. It's not safe during pregnancy, for example. That's something I didn't know. And they don't know whether it's safe in lactation. And there's caution with several medications advised. So, and it needs to be stopped 2 weeks before surgery if the person takes regular licorice. So I'd be quite surprised if the majority of you were already aware of that. So anyway, we stopped the licorice and just used Movicol, which worked very well for the bowels, and her blood pressure came came down beautifully over a few weeks, and we were able to reduce her 5 antihypertensives down to 2 antihypertensives, which was wonderful. And that was the result of the medication review. And so my last one is Monica. And Monica's to illustrate another point, which is it is good to have some specific questions for the pharmacist on occasion that the pharmacist might be able to answer and that you might have difficulty answering. I guess my question about Mary's anxiety is an example of that. But in Monica's case, she's 85, lives by herself. Her daughter, who is her only child, is stuck overseas in the pandemic. And she's fiercely independent. And she refuses a Webster pack. She's actually an ex-registered nurse, and she feels that she is on top of her medications. So she's got multiple chronic conditions, which I think I've probably not even, I haven't talked about her skin conditions, have I there? There's a few things that I've left out actually from that list of conditions. She's got a lot of issues. And she has 15 different medications. And these include puffers because she's got COPD and a reversible component. So she's on one regular puffer and one PRN when she gets wheezy. And last year, so this is a recent one. So in 2020, she was hospitalised with pneumonia. And I did wonder then whether she had been taking her puffers. And she always sounded a bit vague when I asked her. So I asked the pharmacist if she could explore her puffer adherence on the home visit. The other thing is that Monica really was getting a bit vague, and she's on a highly anticholinergic urinary antispasmodic, as a lot of elderly people are for incontinence, and also on an antidepressant because with the separation from her daughter, she's been very teary on occasions. And that's anticholinergic. It's not highly anticholinergic. In fact, it's one they recommend for people with cognitive impairment, but it's nevertheless anticholinergic. And anticholinergic drugs can add together their anticholinergic effects. So the pharmacist can work all that out. And that's not something that I'd be able to do. I don't know. There's a calculator thing or a little program you could use. Of course, we could learn it, but I think it's really good to have the pharmacist doing that for us. And then I wanted the pharmacist to note if there were any ways of simplifying the medication regime for Monica. And so she did a home visit. She identified that Monica was taking 2 over-the-counter medications that I wasn't aware she was taking. And maybe, you know, we should all ask about over-the-counter medications more often. But this review process brings that to the fore. So one of them was aspirin, which she felt would prevent her having a heart attack or a stroke. But she was already on Plavix and she hadn't had a heart attack or a stroke. And so aspirin is no longer recommended for primary prevention. So that could be safely stopped. And folate. She was on folate because she had been on methotrexate for her rheumatoid arthritis, but she was now on a MAB, a monoclonal antibody. She wasn't on methotrexate anymore, but she was still adhering to the folate, which you buy over the counter. And of course, she could stop that now. And then the pharmacist just asked Monica, well, actually, probably at the beginning, what her main concerns were, and the shortness of breath was mentioned. And the pharmacist asked about puffers because when they do the home visit, they get the person to show all their medications. And Monica hadn't put her puffers there. And Monica had to get a footstool and climb up to a cupboard and get a couple of dusty puffers out to show the pharmacist, thereby confirming my suspicion that she probably wasn't taking them regularly. And one was out of date. So the pharmacist was able to re-emphasise the importance of the puffers and linking that to the shortness of breath. And then she calculated the anticholinergic load and identified the urinary medication as particularly high, and wrote in her report that it could be contributing to the cognitive problems. So, sorry, I skipped one there. So what happened? When I saw Mary, we agreed to cease the aspirin and folate. She was fine with that. We had a discussion about the puffers. I'd rung Mary and asked her specifically to bring her puffers, and she brought me 2 shiny new ones in new packs that she'd got from the pharmacist. So clearly she was a bit worried about them being out of date and stuff. And I reviewed her puffer technique, and now I reinforce puffers every time I see her. I wrote to the urologist who had prescribed the anticholinergic urinary medication, and she changed that to Betmega, which is not anticholinergic but does cost money. And I'm not sure if Mary's cognitive function improved. I can't tell you, but she said she felt a bit better on the new medication. And I'm continuing to reinforce that the Webster pack might be helpful, but not so far successfully. And I've also organised for her to have some telephone counselling support to try and make sure that she doesn't need too much antidepressants, or to support her generally, because clearly being stuck at home alone and away from your family in a pandemic is not much fun. So there we are. So both the nursing home medication reviews and the home medication reviews could be very useful for a whole range of reasons. Not least because the pharmacist spends a lot of time just looking at medications with the patient, and they're a different person from you. And so then they're reinforcing good medication behaviour. They can identify adverse side effects. They can identify problems with understanding and barriers to adherence, and they can answer your specific questions about that patient, and that can be very helpful, and it was particularly helpful with the urologist. And I think personally that it's really helpful to liaise with a pharmacist, if possible, before and after the review. I'm chatty. I like talking to the pharmacist, and that's very easy for me because they're next door. But you could also do that in writing. Okay, so I'll leave it there. So I think, Mel, are you going to take this down so that I can see people and answer questions?
Sure.
Thanks, Timothy. That was great to hear some great success stories of how successful the home medicine reviews have been, and it's definitely a good reminder to ask about over-the-counter medications, ask about licorice consumption, and also those practical things like can they open jars and all of it. So yeah, it's good to see those practical examples. So before we answer questions, we might go across to Sandra Fitzgerald from Health Pathways, just to show us where we can find some helpful, useful resources to help minimise polypharmacy.
Thank you so much, Georgia, and thank you so much, Josh and Dimity. What fabulous presentations. I'm a pharmacist myself, and so I was very interested in tonight's webinar. Can you see the Health Pathways login on your screen? And
Yes.
may I invite you all, if you've never logged on to Health Pathways before, you're more than welcome to do it now and have a little look around while I'm just showing you a little bit about it. The login details for Hunter New England are on the left-hand side, and for Central Coast are on the right-hand side. We run 2 different health pathway programs because they're 2 different local health districts with different referral endpoints. But both health pathway teams have a patient info site that is not password protected, and all the information on there has been vetted by a clinical editor like myself or one of our GPs to be evidence-based, good information that lines up with the recommendations in the health pathway. So you're more than welcome to direct your patients off to patient info. Oh, what's going on? I can't move my screen. Oh, there we go. And if you would like, through the PHN, we have little stickers you can put on your computer with these login details so that you don't have to remember them. And we also have cards for patient info that you can give to your patients so you don't have to remember those details either. I'm not going to go into a lot of detail, but across both sites, we've got a lot of pathways for older person's health. On the Hunter New England site, we've got the de-prescribing pathway, which covers a lot of what Dimity and Josh have gone through tonight. And on the Central Coast, we've got a corresponding pathway, which is just called something different, medication management and polypharmacy in older persons. But there's a whole host of pathways you might want to go and have a look at. That's the de-prescribing pathway, which I'm going to show you a little bit more closely in just a second. They're all set out like all our pathways are, a bit of background and then assessment, which is history, investigations, examinations, and then management steps and referral. And that's the corresponding one for the Central Coast. You'll notice up here there's, we usually try and put some related topics on to direct you for some extra information, and that's got the medication management review information, and that's across both the Central Coast and Hunter New England sites. And across the patient info sites, there's also some information that you might find useful for your patients. And I'm just at this point, just going to quickly show you the Hunter New England site. This is the de-prescribing page. Can you see that clearly, or do I need to make that a little bit bigger?
That's good.
Okay, good. It really does talk a lot about what Dimity and Josh were talking about tonight. Assess frailty, talking about the patient's life expectancy. What are their goals and expectations? Have you thought about advanced planning? Have a look at their current medications and so on. But there's some really great stuff down in the management section. There's the links to the home medication review and the RMMR information. But down here in these drop-down boxes, we've got all the de-prescribing guides from Primary Health Tasmania, which are fantastic, and also from the TAG, the Therapeutic Advisory Group, and some of those Josh showed tonight during his presentation, and also guides to using medications in older people. We also have a chronic opioid use and de-prescribing pathway, which talks about how to go about tapering opioids off. And we had a lot of help with both of these pathways from Chris Hayes from the Hunter Integrated Pain Service, which has just been fantastic. Down the bottom of each pathway, we've got a for health professionals section, which has got some more information if you're interested. And this for patient section has got the patient information, which is also then on that other patient info site. If you've got anything you want to feed back to us, just click that send feedback button. We are more than welcome to hear, more than happy to hear from you. And these pathways are only as good as their users. So please let us know what you'd like to do to improve them, if there's something missing, if there's something you don't think is quite correct and so forth. And just to answer one of the questions in the chat about, is there a list of accredited pharmacists? Certainly on the medication management program page, and look, you don't have to know how to get around health pathways. You can just put HMR in that search engine, and that page will come up. And just under here is where you'll find the list of accredited pharmacists. It's through the Association of Consultant Pharmacy, and there's a really great search engine that you can do by postcode and specialty. So encourage you to go and have a look at that. Josh also talked about prescribing in renal impairment, and we've developed a really great prescribing in renal impairment pathway with the renal pharmacist at the John Hunter Hospital, and that's got some really great lists of things, you know, medications that increase the risk of hyperkalemia, medications to use with caution in renal impairment, and down here we've got some very specific drug information and what you should do with these things in terms of renal impairment. I think that was probably pretty much all I wanted to share with you tonight, but if you've got any questions at all, please just pop on. Both the Central Coast site and the Hunter New England site have this fabulous send feedback button. Click that and let us know your thoughts. Thank you very much, Georgia.
Great, Sandra, thank you. And yeah, thank you for answering the first question, which was, is there a list of pharmacists that do the home medicine reviews? And that might be something that you're aware of, Josh. Do all pharmacists offer them, or because again, you guys are very busy and it might be something that some pharmacists may be too busy to partake in?
Yeah, I mean, look, to be an accredited pharmacist is like quite a comprehensive, like, further education. So I would think probably less than 10% of pharmacists could be accredited pharmacists. Look, as far as where to find them, that's a really good question. It's something I've never really considered. So look, I'm certain with the, I might actually see if I can find information regarding that on who is accredited. Are you aware, Sandra, of a list of accredited pharmacists? I'm certain there is there's a newsletter that goes
That's the list. The list that I just showed, that if you click on that, that will give you a list in your local area. But most community pharmacies have got someone on their books that they can ring. Like, yeah, every community pharmacy, if the owner or the person working there themselves is not accredited, they will absolutely have someone they can call to do it.
And particularly if there's a reasonable number of referrals from a particular GP or a particular practice, most pharmacists like myself, like me, for instance, a GP at Newcastle said, look, I've got a list of like 30 patients here that I would like to do medication reviews for. Look, I myself would be more than happy, like it's only an hour away. I would try to line up a number of reviews in a single day. And most accredited pharmacists would be happy to do that. If it's erratic referrals where, you know, we're getting one here and there, you probably are better off going through your local pharmacy. Because like Sandra said, most local pharmacies, if they don't have someone employed, often they have, you know, like someone who comes through their pharmacy.
Right. And another question was, when billing the 900 item number, because obviously there's quite a few steps involved. So when you do get the final plan from the pharmacist and you send a response back to the pharmacist, does the patient have to be present, like, to bill that item number? Just like with other item numbers, usually it requires a face-to-face consult. Are you aware, Dimitri, or anybody?
Well, I think we're supposed to discuss it with the patient.
Yep.
Make an appointment. And bill the 900 then. And write my comments then as part of that appointment too, and then just, you know, email it off to the pharmacist. So that's my practice, and I think that's perhaps safer, but I don't know if it has to be face to face.
Yeah, it does make sense. And I did, because I was trying to find the answer looking up the MBS, and especially in regards to co-billing as well. And I think if you've seen the patient for something unrelated, you could co-bill an item number, but obviously if the consultation is just to discuss the medication review, then you'd obviously only do the item number 900.
Yeah,
so,
well, I think that claim number is, I think to in order to claim that officially, I believe that, like you said, the circle of care, I think that's meant to include a final discussion. Whether or not that aligns with how your own practice takes bookings, I'm not too sure. But like you said, Georgia, I'm assuming that would assume that the only thing you're talking about is that medication review, where if there's another, like a extended consultation, I'd assume that would be a separate.
Yeah. And then there's a final comment about licorice, that it's a delicacy amongst the Dutch. So if you've got any Dutch patients, they love their licorice, so don't forget to ask. And it might
I can attest to that. I'm half Dutch and we have a lot of licorice in our house.
Right. Isn't that interesting? You should do your blood pressure after a bout of because I can tell with some of my it's so delicious, and sometimes people just buy a bag of it and I do their blood pressure. I go, you've been eating that licorice again? They go, oh yes. I should I'll wait till next week.
Maybe we should give it to our elderly patients that are hypotensive, that have a bit of postural hypertension.
Yeah,
maybe we
true.
give them licorice.
Okay, so I just wanted to thank you all for being with us tonight. Sorry, Josh.
No, you're right.
I cut you off then.
No, you go.
I just want to say thank you, Georgia, for facilitating this evening. That was great. Some great questions and great topics. Content has been covered. Thank you to Sandra as well for that Health Pathways information. Health Pathways is always a great resource for everybody, so strongly encourage you to utilise that. Thank you, Josh and Dimity. Your presentations were very interesting, and we really appreciate you being here with us tonight, so thank you. And just a reminder to everyone to please complete the poll. It will pop up at the end of this session, and a copy of the presentation and the recordings will be available in our education library over the coming days. Thank you, everybody. Have a lovely evening, and we'll see you all soon. Bye. Good night.